It's my great pleasure to announce the last speaker of this session of today. And we already heard a lot about the institution behind. So the BfArM is one of the institutions that is taking the lead in the Modellvorhaben, Genomsequenzierung. And Andreas Till is the representative of BfArM for this particular job. You started this year, as far as I learned from your CV. So it's brand new and it's a lot of work ahead of you. But we are very much looking forward to your presentation and your view on genome data handling in Germany. Thank you very much for coming.
Yeah, thank you very much for having me. Thanks for the kind introduction. Thanks for the kind invitation to this awesome meeting. I already learned a lot. Actually, in the coffee break, I was testing my grip strength as a surrogate marker of aging, as we heard from the NACO talk. And I have the feeling it's for me time to worry now a little bit. So thanks for passing on this information. So my name is Andreas Till. I'm by training, I'm a molecular cell biologist. I joined BfArM in April. BfArM is taking over the role as the operator of the data platform for the model project on genome sequencing. And it's my pleasure to introduce you to the current state and maybe some of the perspectives of this very challenging and very interesting model project on genome data. Oh, okay. So the model project is part of a national strategy, Genome-Phenome, which aims at integrating genome medicine in healthcare. And the project which started already, or the initiative which started in 2019, has taken several steps successfully over the last few years, enabling us now to start restructuring or to start taking off with the organizational, with the infrastructure for assembling genome data on patient materials and using these for both health benefits for treatment strategies, as well as in the future for research purposes. And of course, that's an important topic. And here's one example taken from rare diseases, where we have a number of something like in the range of 7,000 to 8,000 different rare diseases that are with a majority based on genetic background, so pathogenic mutations. And what you can see here is that over the last few years, we have seen a dramatic increase in the number of genes or gene variants that have been linked to certain diseases. And this increase is still linear. So we're still engaging in identification of pathogenic gene variants of genes, and there are alterations which are linked, and how they are linked to diseases, and maybe how they are also can be used in the future, not only for diagnostic, but also maybe for treatment options. So our model project aims to improve the care for patients suffering from rare diseases and oncological diseases. That's a starting point for the model project, and we hope in the future these disease entities will be expanded to other disorder types by establishing genome sequencing in healthcare. We have a time frame of something like 5 years, starting now until end of 2028. And the major aim, as said, is the integration of genome medicine knowledge into routine healthcare. And I think that's one of the unique points. The reimbursement, the payment of the data provision will be organized by health insurance companies. So both the universities as well as the health insurance companies are both working together to gain a lot of high quality data and use them for patient care and research. Starting with rare diseases and oncological diseases, I have to mention that oncological diseases also encompass hereditary cancer predisposition syndrome. So that's a kind of entity that is a little bit between rare genetic diseases and oncological diseases. And we're taking benefit from the experts in the field, which have been working on these disease entities over the last decades. The core element is that we want to establish an infrastructure that is able to take up genomic data and also clinical data from the patients and to feed them back into the health treatment, into the routine healthcare system. The general concept is that we do not want to start from scratch. We do not want to build something completely new, but we know that in Germany we have quite a nice infrastructure that is for once based on the clinical networks for certain disease types that are also using well-established infrastructures. So data transfer pathways and documents. And in addition to this, the Medizin Informatik Initiative use also suitable structures, also consent documents, trust centers, and so on. So a lot of knowledge. And we want in the future to use the already existing infrastructure and use them for our purposes. With a data storage system that will be decentralized, so we will have several clinical data nodes and several different genome research centers storing the data. But we will have one, or we are currently establishing one central governance and one central independent trust center for all this entire structure. The operation itself is organized in several steps. So we're currently in the phase, in the starting phase of the project as the legal requirements just got into place in summer this year. So we're currently kicking off, and we hope that over the next 5 years, we will have several phases of expansion. We want to be flexible at the very beginning and then scalable at later time points, increasing the complexity of the system and also influencing or improving the harmonization steps and also the integration and expansion of other data sets. So starting easy at the beginning and then expanding over the time. As mentioned, we will start with rare diseases and also advanced stages of cancers. And we are currently estimating that per year, we will have in the range of 5,000 to 10,000 of both of these entities. That means in the course of the 5 years, we are expecting numbers of patients to be included, something 10,000 to 20,000 patients per year. And that would mean in terms of genomic data, in the range of 10 to 20 petabyte in total data. And of course, we are heavily relying on the already existing expertise and all this, also the structures which are already built up and which we can use for being successful in this project. How do patients enter the project? Patients are presented at their university hospital. We have 28 university hospitals currently taking part in the model project. They are presented to a board where inclusion criteria are discussed, where a decision is made on whether or not genome sequencing is a benefit, might be a benefit in this special case. Then the patients are informed and can sign their informed consent form. Then genomic diagnostics are performed, and this will feed back into the board decision on next steps, for example, also therapeutic proposals, so options based on the genetic hallmarks or genetic makeup of the patient in how far a certain therapeutic option might be beneficial for the patient. These steps are taking part as we speak, because we know that at least 6 university hospitals already started with informing their patients and with inclusion of patients into this model project. So we are expecting that data transfer of genomic and clinical data will start in the next few months after all these steps are passed through by the patients. Which type of sequencing information will be obtained? So maybe you know, there are several technologies applied, and we are actually encompassing or envisaging that several different types of technology also applied in this model project. We will have next-gen sequencing, gene panel sequencing, short-read exome sequencing, and whole genome sequencing, starting with short-read genomes and then slowly, stepwise integrating long-read genome data in the course of the project. It's important to note that for the rare diseases, only whole genome analysis will be performed, while for oncological diseases, based on the decision of the board, a certain ratio of whole genome, whole exome, or panel sequencing will be applied. So there's a certain budget, a certain ratio of this technology on how they can be used, and this is also of course also reflecting how much the data will be stored in the data platform. So how is this data platform made up? As mentioned, we have 28 university hospitals starting with or being integrated in the model project. The clinical data, and I will come to the details on this in a moment, the clinical data will be transferred to so-called clinical data nodes, which are organized or which are set up by the clinical networks. The genomic data, of course, a totally different type of data size or data content and type. Will be stored in genome research centers. All of these genome research centers represent GHGH data hubs. And we are very grateful to the GHGH structure for providing or for assisting in provision of this very complex data platform. The BfArM itself serves as an operator of this data platform. So everything which you can see here within this gray area would be considered the data platform. And our local or the central trust center at the Robert Koch Institute is authorized to give the specifications for pseudonymization processes, because within this data platform, we are only handling pseudonymized data. So there's no patient ID, no identification possibility within this data box, within the platform. So currently we have officially approved 7 clinical data nodes and 6 genome research centers. We expect that over the time course of the model project, the number and the structure of this will change a little bit. We expect that more hospitals will join, and also that the entire structure will increase based on the demands for data provision. How is the reimbursement enabled? The data nodes, both types, will represent QC reports on the uploaded data. We're currently working on the QC parameters that are defined for each of the data node types. And these QC reports will serve us to initiate a validation token that will be given back to the hospitals, and the hospitals themselves can use a combination of different validation tokens for clinical and for genomic data to ask for reimbursement with the health insurance companies. So that's the way the entire reimbursement strategy is working. So that means we are in need of the QC reports from the data nodes to initiate the reimbursement strategy. And of course, that's the motivation for the participants to serve or to upload and to provide high quality clinical as well as genomic data. These are the clinical networks that are operating the clinical data nodes. Comment? No. Okay. That are operating the clinical data nodes. So as you can see, we have been using we are currently establishing the network based on the already clinical networks with a high focus on their specialty area. And of course, that enables or that ensures that the already existing transport pathways and protocols are beneficial for our data upload procedure as well. It's a little bit different for the genome research centers. These are operated by academic research institutions. All of them are representing GHGH data hubs. And of course, this enables a high connectivity between and a high standardization also of the different data hubs, but also the ability or the possibility that GHGH will help us in future efforts for national and international connectivity and exchange and shared usage of the data. So which type of data will be submitted? The categories of the data and the content is defined by law. We are aiming for harmonized and specific data sets. These specifications are currently being finalized and will be shared with the data generating hospitals in the next few weeks. The QC parameters, which will help us to create these validation tokens, are also defined by our institution in discussion with the QC, with the data nodes. And we will have these QC reports shared or collected in order to create then the validation token for the hospitals who provided the data. So the type of data that will be uploaded, the genomic data, we are aiming for raw data sets for the sequencing data. This will be FASTQ and BAM files. Of course, this depends on the type of indication. So as mentioned, rare diseases will only have whole genome data. For oncological disease, we will have a mixture of sequencing panels of exome and genomic whole genome data. We are also collecting sequencing metadata, so information about the types and also the equipment and the pipelines used. And we will also collect quality metrics, for example, coverage of the genomic sequencing and so on. On the clinical data level, we will have general data on demographic level, also the board decision, of course. We will have clinical data on diagnostics, on therapy, but also, and that's one important point, follow-up data. So we will also want to collect follow-up data for the patients to see in how far genomic sequencing has improved therapy or provided earlier or quick diagnostics, and how this is affecting the treatment options and also the health benefits of the patients. So as mentioned, within this data platform, none of the participating units is able to re-identify the patient. So we have no patient person identification data here. This is enabled by a certain set of specifications that are provided by the Robert Koch Institute. We will have so-called transaction numbers for providing the data along with this information to the data nodes. So the local trust offices of the healthcare providers will provide the data in combination with these TNC or TNG numbers. That means the two data packages will have two independent transaction numbers. And also the quality reports will encompass or will include these transaction numbers and will be delivered to us. And as a kind of response pattern to the quality reports, we will get the confirmation back to the healthcare providers who can re-identify or map the TN to their patient and then ask for billing reimbursement with their companies. Oh. Can I go back? How can I go back? Okay, so how do we want to provide access to the data, or how do we ensure usage of the data? The use of the data in general is organized or is motivated by the purpose of the project. So we are currently setting up a portal, an access proposal portal, where interested applicants can submit their proposals. Which we will test with a number of experts to grant access to the data, but the data will not, at the current planning stage, will not be provided in a raw data format unless this is absolutely necessary. But we will provide a secured processing environment or several of those which might be linked very closely to the data nodes, and within these processing environments, data services will handle the calculation steps, and the results of this data will be fed back to the applicant. Maybe we should add one more arrow, because I like the concept at the beginning very much, that of course we want to feed back this data back into the health sector. So in my opinion, these data which are provided after the analysis also should be made available, or should be influencing the healthcare providers in order to increase treatment strategy, or to help us with understanding background of diseases and maybe open avenues for novel treatment strategies. Here's one example on how this data could be used. So because one might ask, why do we have to go for whole genome sequencing instead of much cheaper panel sequencing or just exome sequencing? And here's one example where a pathogenic variant in a non-coding region was identified in a child with a very rare disease. So this variant in the MBD5 gene, and I think this is a transcriptional regulator which is involved in brain development and also in neurological functions. This variant would have not been identified by panel sequencing or by exome sequencing. So these are one of the examples, and we have several of these examples where whole genome sequencing is superior in terms of information as compared to other forms of sequencing. And one of the aims of the project is to see or to analyze in how far and in which cases whole genome sequencing is superior and gives a higher health benefit to the patients. So the next steps will be now testing the individual data transfer steps. We are currently implementing transfer procedures for the data themselves, also for the QC parameters. We are setting up contracts between the different units. We are into the process of harmonizing the data parameters which will be provided. And we are also working on optimization or setting up a platform for data usage in the future for healthcare as well as research. And the last step would be, of course, to re-evaluate the data that come out and also the benefits and checking the benefits of the data provided and have a gradual expansion and also opening to other activities in the field and also on the national and international level. Our common goal and of all the participating units, of course, is to improve patient care by using genome sequencing, genome medicine strategies in healthcare, but also for research purposes. With this, I want to finish up. We are currently also, of course, very interested in using the GHGH structure also for outreach to other international activities, and we are highly interested to see in the future linkage and mutual crosstalk with activities on the European level. We are looking out for improving our communication strategy. So we have established a number of information events also now coming up for the patients themselves, because they are, of course, in need of information. And this topic has been mentioned before. And finally, I want to thank you all for your attention and just mention one housekeeping issue. We are currently hiring. And we're looking out for both IT experts as well as data scientists and experts and people in the communication field, because we want to expand our team. We have a big task ahead of us. We are very grateful to GHGH and all the other involved partners and looking forward to future developments. Thank you very much.